The 2026 sepsis guidelines are out, and they don't introduce a new drug. They don't introduce a new bundle, but they do challenge how we've been recognizing and even defining sepsis at the bedside. If you're still relying on qSOFA alone, you may already be behind. In the next few minutes, we'll break down what actually changed in the new sepsis guidelines, and more importantly, what it means for how you practice. We'll also look at a large study that questions whether we even need serum to classify pleural effusions. And finally, we'll step back into physiology and revisit vasopressin, when it helps, when it harms, and why it's often misunderstood. These are not theoretical updates. They directly affect decisions you make every day on rounds. Welcome to This Week in Pulmonary and Critical Care Medicine. Pleural effusions are everywhere in clinical practice, and one of the first decisions we make is simple. Is this an exudate or a transudate? That decision determines everything that follows: further testing, invasive procedures, even the urgency of workup. For decades, we've relied on Light's criteria. That there's a problem. Light's criteria are very sensitive, but not very specific. They tend to overcall exudates, especially in patients with heart failure who are on diuretics. And they require serum sampling, which adds complexity. So the question is straightforward. Can we do just as well using pleural fluid alone? This study from ERJ Open Research tackled that question in a serious way. Not a small cohort, not a single center pilot, but over 7,280 thoracenteses divided into a derivation cohort of 5,000 and a validation cohort of 2,280 patients. That scale matters. It's one of the largest data sets we've ever had for this question. They tested a simple alternative, a pleural fluid only triple combination: protein greater than 3 grams per deciliter, LDH greater than 250 international units per liter, or cholesterol greater than 55 milligrams per deciliter. If any one of these is positive, you call it an exudate. Now, here's where things get interesting. The diagnostic performance? Essentially identical to Light's criteria. Sensitivity was 99% versus 98% in the derivation cohort, and both were 98% in validation. So you're not losing sensitivity, and that's critical, because missing an exudate is what we fear most. But specificity improved, and this is the real clinical impact. This triple combination correctly reclassified about 19 to 20% of transudates that Light's criteria had mislabeled as exudates. Think about that. That's fewer unnecessary CT scans, fewer pleural biopsies, less downstream testing, less patient anxiety. Now, there was a small signal of slightly more false negatives in one cohort, but this did not persist in validation, and overall performance remains equivalent. They also tested a simpler double combination. It had even higher AUC, but it missed more exudates, and that's the trade-off you can't accept clinically. So what does this mean for practice? It doesn't mean we abandon Light's criteria tomorrow, but it does challenge the assumption that serum is always required. In settings where blood sampling is delayed, unavailable, or impractical, this gives you a validated alternative. And more importantly, it highlights something we often ignore. Light's criteria are not perfect, and maybe it's time we stop treating them as such. Sepsis hasn't changed, but how we think about it has. Because the biggest shift in the 2026 guidelines is not a drug. It's not a bundle. It's a mindset. Let's start with the most important concept. Sepsis is not a protocol problem. It's a recognition problem. The guidelines are very explicit about this. Sepsis remains a clinical diagnosis, not a lab value, not a score, not a biomarker. And importantly, you cannot rule it in or out with a single test. That sounds obvious, but in practice, we've drifted. We've leaned heavily on lactate, procalcitonin, qSOFA, as if they define the disease. The guideline pushes back. These are tools, not answers. Now this connects directly to screening. One of the clearest updates, qSOFA is no longer acceptable as a standalone screening tool. Not because it's useless, but because it misses patients. The data consistently shows that NEWS, NEWS2, MUSE, and even SIRS are more sensitive for detecting sepsis. So the shift is simple. We prioritize sensitivity over specificity, because missing sepsis early is more dangerous than overcalling it. But here's the nuance. qSOFA still matters, not for screening, but for identifying deterioration. That's a subtle but important distinction. Now let's move to what may be the most practical shift, and honestly, one of the most underappreciated. The guidelines are no longer just about individual actions. They are about systems of care. There is now a strong recommendation for sepsis performance improvement programs. That includes screening systems, standardized protocols, and quality improvement infrastructure. And the signal here is strong. Quality improvement initiatives were associated with an approximately 34% relative reduction in mortality in observational data. That's not trivial. So what does this mean in practice? It means sepsis care is no longer just what you do at the bedside. It's how your system responds before you even see the patient. This ties into another key addition, code sepsis or sepsis response teams. These are essentially rapid response systems for infection, multidisciplinary, triggered early, focused on speed. The evidence is mixed, but the direction is clear. Faster recognition leads to faster antibiotics, leads to better outcomes. Even when mortality data is inconsistent, process improvement is consistent. Now let's talk about antibiotics, because this is where many clinicians feel tension. The guideline draws a very important distinction. Not all possible sepsis is the same. If the patient has septic shock, antibiotics immediately, ideally within 1 hour. No debate. If the patient has clear sepsis without shock, still early antibiotics, again within 1 hour. But here's the nuance. If it's possible sepsis without shock, you are allowed to pause, briefly. You have a window, up to 3 hours, to reassess, gather data, and decide if infection is truly likely. This is a major conceptual shift. It acknowledges a reality we all see. Up to 30% of patients treated as sepsis don't actually have infection. So now the model becomes fast when certain, thoughtful when uncertain. And that balance between urgency and stewardship is probably one of the most mature aspects of this guideline. Now let's move to resuscitation, because here, interestingly, the guidelines did not change much. Fluids, still 30 milliliters per kilogram within the first 3 hours, but with a stronger emphasis on reassessment, individualization, avoiding over-resuscitation, and vasopressors. Here's a practical shift. You no longer need to wait for a central line. Peripheral vasopressors are acceptable. That's a workflow change. It removes delay, and it reflects real-world practice. And finally, MAP targets. The standard remains 65 millimeters of mercury, but for older patients, you can accept lower, around 60 to 65 millimeters of mercury. Why? Because pushing higher pressures increases harm without improving outcomes. So if you step back, what is the real message of the 2026 sepsis guidelines? It's this. Sepsis care is no longer about rigid bundles. It's about early recognition, clinical judgment, system efficiency, and thoughtful intervention. And if you miss that shift, you'll keep following the protocol, but still miss the patient. Let's shift gears and talk physiology, because vasopressin is one of those drugs that people use without always understanding when it actually helps. Start with the basics. Most vasopressors work through adrenergic receptors, norepinephrine, epinephrine. They increase vascular tone through catecholamine pathways. But vasopressin is different. It's non-adrenergic. It works through V1 receptors, and that matters because in shock, especially prolonged shock, adrenergic receptors become less responsive. You get catecholamine resistance. That's where vasopressin becomes useful. Now here's the key physiologic concept. Vasopressin increases systemic vascular resistance, but it has relatively less effect on the pulmonary circulation. Why? Lower receptor density and nitric oxide-mediated vasodilation in the lungs. That creates an important clinical advantage. You can increase blood pressure without significantly worsening pulmonary vascular resistance. So in patients with right ventricular failure, this matters a lot. Now think about different shock states. In distributive shock, vasopressin deficiency is common. Levels drop, and replacing it makes physiologic sense. In cardiogenic shock, it's more complicated because increasing afterload can worsen cardiac output. So the benefit depends on the phenotype. Low SVR cardiogenic shock, helpful. High afterload states, potentially harmful. Another advantage, vasopressin is not arrhythmogenic, unlike catecholamines, and it may actually reduce atrial fibrillation by sparing catecholamine use. But let's not ignore the downsides. This is a potent vasoconstrictor, digital ischemia, mesenteric ischemia. These are real risks. Reported rates up to 8 to 10% for digital ischemia and higher for mesenteric ischemia in prolonged use. So dosing matters, duration matters, patient selection matters. So how should you think about vasopressin? Not as a second-line reflex, but as a physiology-driven tool. Use it when you need vasoconstriction without more catecholamine. You're dealing with vasodilatory physiology. You want to reduce arrhythmia risk. Avoid it when afterload is already the problem, perfusion is marginal, ischemic risk is high. This is where critical care is heading. Not protocol-only care, but physiology-guided decisions. So this week, 3 shifts to keep in mind. Sepsis is moving away from rigid scoring and back toward clinical recognition and system performance. Pleural effusion classification may be simpler than we've made it, and vasopressin reminds us that physiology, not habit, should guide how we treat shock. If you value clear, practical updates like this, subscribe for weekly insights in pulmonary and critical care medicine. Until then, this is Dr. Aladdin Sagar signing off.